Hello guys, welcome to my YouTube channel Notes by Medico. Today we are discussing about operative vaginal delivery, which includes forceps and vacuum delivery. Indication for operative delivery includes prolonged or arrested second stage, inadequate descent or rotation. Non-reassuring fetal status when the head is sufficiently low for safe vaginal birth. Maternal exhaustion or inability to continue effective pushing. Maternal conditions where shortening the second stage is desirable, as in cardiac disease, preeclampsia. Selected situations requiring controlled delivery of the head, as in preterm, VBAC. There should have some prerequisites before applying instrument: fully dilated cervix and ruptured membranes. Engaged head, well rotated in forceps. Vertex presentation suitable for the chosen procedure. Pelvis clinically adequate, no suspected cephalopelvic disproportion. Bladder emptied. Adequate analgesia, anesthesia. Informed consent and explanation of benefits, alternatives and possible complications. Skilled operator, appropriate equipment, neonatal support and ability to perform cesarean delivery if the attempt fails. Let's discuss about contraindications for applying instruments: unengaged head or uncertain fetal position, station. Incomplete cervical dilatation or intact membranes. Suspected significant cephalopelvic disproportion, non-vertex presentation, except highly specialized circumstances, not routine OVD. Certain fetal bleeding or bone mineralization disorders are contraindications to vacuum. Do not persist with difficult application, failed descent, or excessive force. Reassess and change the plan. Picture of forceps and vacuum. Principles for forceps delivery: confirm fetal head position and station before application. Apply blades correctly around the fetal head with appropriate pelvic orientation. Check application before traction. Correct placement, no maternal soft tissue entrapment, and ability to articulate locks when applicable. Blades equidistant from sagittal suture and posterior fontanelle midway between blades. Traction should be gentle, controlled and along the pelvic curve, first horizontal and then upwards and forwards. Coordinated with contractions and pushing. Abandon the attempt if application is incorrect, rotation is not achieved easily, or descent does not occur. Principles for vacuum delivery: confirm position and station. Principles for forceps delivery: confirm fetal head position and station before application. Apply blades correctly around the fetal head with appropriate pelvic orientation. Check application before traction. Correct placement, no maternal soft tissue entrapment, and ability to articulate locks when applicable. Blades equidistant from sagittal suture and posterior fontanelle midway between blades. Traction should be gentle, controlled and along the pelvic curve, first horizontal and then upwards and forwards. Coordinated with contractions and pushing. Abandon the attempt if application is incorrect, rotation is not achieved easily, or descent does not occur. Principles for vacuum delivery: confirm position and station. Select an appropriate cup. Place cup symmetrically over the flexion point, located on the sagittal suture 3 cm in front of posterior fontanelle. Create vacuum gradually after ensuring that maternal tissues are not included. Recheck at 0.2 kg per centimeter and increase to maximum of 0.8 cm. Traction is applied in line with the pelvic axis and coordinated with contractions and maternal pushing. Reassess descent after each traction effort and release the cup after delivery of the head. Stop if there is no progressive descent, repeated cup detachments, or the procedure is becoming unsafe. Maternal complication includes perineal lacerations, including 3rd and 4th degree obstetric anal sphincter injuries. Postpartum hemorrhage from genital tract trauma and uterine atony. Pain, hematoma, infection and delayed recovery. Urinary retention and transient urinary symptoms. Long-term pelvic floor dysfunction may occur, particularly with severe perineal trauma. Neonatal complication in vacuum: scalp abrasions, chignon, cephalohematoma and, rarely, subgaleal hemorrhage. And in forceps: facial marks, bruising and, rarely, facial nerve injury or ocular trauma. Both. Risk of birth trauma: serious intracranial injury is uncommon but important. Neonatal assessment should be prompt when there is difficult extraction, significant bruising, abnormal neurological findings or concern for bleeding. Comparing vacuum and forceps. Vacuum. Generally easier to apply, no anesthesia, promotes auto-rotation, causes less maternal perineal trauma than forceps, but more neonatal scalp trauma and cephalohematoma. Forceps. Quicker, no maternal effort, less cephalhematoma, can use in preterm, face and breech but associated with more maternal perineal trauma. Vacuum is generally avoided in very preterm infants and in conditions increasing neonatal bleeding risk. Choice depends on fetal position, station, urgency, gestational age, operator expertise, maternal factors and local protocol. Failure means inability to achieve safe progressive descent or delivery despite appropriate application and traction. Immediately reassess fetal position, station, application, maternal condition and fetal status. Do not repeatedly attempt instrument application without a clear rationale. If OVD fails, proceed to cesarean delivery when vaginal birth is no longer safe or feasible. Trial forceps, vacuum, in an operating room prepared to abandon if procedure fails.